Good afternoon, good morning to some of you. Gail Iwamasa here, chair of the VA section of Division 18. I'm so happy to share with you all our webinar today, Implementation of the Public Health Approach in Suicide Prevention, Our Roles Now and Over Time to Save Lives. We have two amazing presenters. They are probably the busiest people in the United States of America these days. I've got these fabulous, amazing bios, but in the interest of time, I am not going to read all of these because, well, it would take up the entire time, if that's all right with you guys. But suffice it to say, Dr. Matthew Miller is the director of the Suicide Prevention Program in VA, and he has been leading our efforts in OMHSP since 2019. He's got an amazing group of people in an ever-expanding office who are really dedicated to ensuring that we're doing everything that we can to save veteran lives. And so thank you so much, Matt, for taking time out of your busy schedule to do this webinar. His partner in crime and suicide prevention is one of my favorite all-time former bosses. Yes, Dr. Kearney was my boss, an amazing one at that. Dr. Lisa Kearney is the Deputy Director of the Suicide Prevention Program in the Department of Veterans Affairs. And she is also currently, because that's just not enough work for her, she is also currently the Acting Director of the Veterans Crisis Line. So she is so amazing, and she's doing it all and completely underpaid, but just an amazing advocate for veterans. And so thank you both for being here today. With that note, I am going to try to mute myself and let you guys rock and roll while I try to figure out where I can find the link for the CEUs and put that in the chat while I'm doing your slides. So in any event, I'm going to stop my video and turn it over to both of you.
Thanks, Gail, and thank you for helping with the slides and for giving us this opportunity to talk about this topic with this group. As Gail said, I'm Matt Miller. I'm the director of suicide prevention for the VA. Yes, there are two Matt Millers in suicide prevention. I am him. I'm one of them. The other is we've had the privilege of working with him, and he's done some excellent research on lethal means safety and various aspects of suicide prevention, and his work is wonderful from a public health perspective. I'm joined by Dr. Lisa Kearney. These names on here really should be side by side, and they should kind of rotate around, because that's really how the relationship works, and that's how our office works. I think the one most important thing Gail said in the intro with regard to me was he's got a great team, and that's it. That's what you need to know. This and what we've developed and what we're going to talk about today is all a byproduct of the team. We're going to talk about a public health approach to suicide prevention, and on occasion we're going to get into numbers. We're going to then, from the numbers, talk about plans and strategies, and that's important. But it's also important that I communicate to you that behind the numbers and behind the plans, it would be a false presentation for me to just leave it at that level and not share with you that there's also a personal connection, and you'll find that across our team as well with regard to suicide prevention. And that may exist with you as well sitting here, and may be a reason why you're interested in sitting here on a Friday afternoon, which we appreciate. My personal connection, I'm a clinical psychologist by background, and I was in the United States Air Force, and I was assigned to a base. I was chief of mental health, And long story short, one of my best friends, a Marine instructor pilot at the base, died by suicide. That set me into a period of lots of questions, frustratingly few answers, a little bit of anger, and a little bit of bouncing around in terms of all questions existential and what you do with life. That led me to a critical point where I came face to face with some facts regarding veteran suicide. I was actually watching a TV show, believe it or not, and I was watching the show, and I had that feeling of, where have I been and what am I doing? And how can I not pay attention to this? And how can I not do something in this effort because of what I've been through and what a lot of people have been through, specific to the situation I went through and to other very painful situations. So I joined the VA at that point, started as a chief of mental health. A few years down the road, I find myself here. And it's with a commitment to doing everything we can from the bottom of our hearts to the fullest of our heads, and all points necessary in between to address suicide prevention in a meaningful way. You know, the next slide, I think, will tell you about some objectives that are part of this presentation. And the objectives sound really good. They're the kind of objectives that you write when you're doing CE and you need to place those. And yeah, we're gonna do these things. On another level, though, what we're really gonna do is we're going to talk a little bit about my journey through thinking about, considering, formulating what I believe to be core tenets, core truths within suicide prevention, and what we as a team, and the team has helped to develop in me as core beliefs. We're going to talk about then how those core beliefs translate into plans, and how those plans translate into, or emanate from, better stated, a public health approach. Now, regarding the latter, I don't know how many of you have listened to talks, and maybe the talk said, you know, we're going to take a public health approach to this. We need a public health approach to this. I have an MPH, and there are times when I sit and I listen to that and I think, I don't know what that means. What does that mean applied to this situation? I don't get it. So one thing that the team's really good at is pushing beyond commonly used big terms, which are, they're not bad, but what does it mean? So we're going to spend some time trying to reflect to you the process we've been through as a team, and I've been through, converting maybe what I learned in a University of Michigan classroom about public health, what I experienced personally and directly with a friend, what I've experienced as a clinician, and how it comes out then in a meaningful way for VA suicide prevention. I hope in doing that, it gives you some ideas in the end for what we espouse as the number 3 core tenet, and that is everyone has a role to play with regard to suicide prevention. If you emerge from this with a intensified fervor, desire for exploring core foundational truth number 3, and delving into the research in a public health model and picking apart what we're doing and offering feedback, that would be a successful time here together. So during this time, Lisa's of the impression here that she's going to help with chat and run that. I'm now going to destroy her illusions of that. I'm going to say, you know, you want me to break it up from me being the presenter. So there's going to be times where I look at Lisa and I say, Lisa, please help them out. Give them a break from me. Come on in, and what do you have to say about this? So we'll do that as we go as well. But we'll be watching the chat as well if you have any comments here as we go. And Lisa, if you see anything right away, feel free to say, hey, Matt, do your woohoo. Got a comment here that we need to address. Next slide.
I liked the mimicking of my voice there, but it's not woohoo, it's yeehaw. Let's get it straight, Matthew.
Okay. All right. So the model that we're talking about here, when we talk about a public health strategy, and I use the air quotes on purpose because, again, what does it mean? From our perspective, and what has evolved with us as a team, is that the public health approach is founded on a focus upon an implementation of two very important components. And a bit like an equation, if you have public health on one end of the equal side, you have to have all the variables in an additive way on the other side to get to the equal sign. We really believe that's true when it comes to the two broad approaches that necessarily constitute the public health approach. First, there's the clinically based aspect of things. Now, how does that apply to suicide prevention? We know that 60% of the veterans who died by suicide, according to our latest data, in the last year of our latest data, had a mental health diagnosis. Most common mental health, most frequently occurring, better stated, mental health diagnoses within that group, depression, anxiety, substance use disorders, and serious mental illness. Co-occurring sorts of conditions are often sleep problems, pain issues, and general medical conditions. So with that population, we know that the best possible clinical care with regard to suicide prevention, intervention, and postvention is critically important. You are not going to flatten the curve with suicide prevention without the highest quality clinical care across a continuum of care, and including all aspects of the continuum of care within mental health. So you're going to hear parts of our plan that build upon that are founded upon that belief, and I believe that truth. The other aspect is community-based. Community-based aspect recognizes that there are dimensions of suicide and there are dimensions of suicide prevention that impact the clinical, but aren't necessarily best, most directly, or even indirectly in some cases, approached or engaged within a clinical setting or within the walls of a clinical setting. There are things such as variables such as financial instability, occupational instability or unemployment, access to lethal means within the community, access to general health care and emergency care within the community, community enrichment resources, such as recreation resources, community air, community crime rates. There are many of these dimensions that have a meaningful relationship with suicide prevention and need to be addressed as part of a comprehensive plan. Now, there's one word before we go on to the next slide that I want to maybe caveat a little bit. It's that word that's above public health, and it says full. All right, so here's my NPH disclosure on the use of the word full. Technically, from a public health perspective, it's not completely accurate, because a truly full public health approach to suicide prevention would certainly take a look at clinically based interventions, and it would certainly take a look at community-based interventions, but it would also take a meaningful look at ecological, broad sorts of issues and dynamics that the individuals involved don't have to do anything necessarily to benefit from. So examples would be policy. What are some key policies that impact a community as a whole? And if you were to change them, the individual doesn't have to go to therapy. The individual doesn't have to go to a park. The individual doesn't have to have a highly rated medical center within 5 miles of their house to benefit from it. So I do want to make clear, and I think that's important to think about within this context with APA Division 18, that there are important aspects of a true full public health model that attend to some of these really big picture policy, cultural, social issues that are really important to attend to in public health and suicide prevention. We're just not at the vantage point or leverage point that's something that we can directly do. Others can, such as maybe APA, for example, or others. So next slide before I get into trouble. All right, so that's the equation of a public health model. Now let's talk about the core tenets that the team has developed as our foundation, and I have come to terms with and have peace in my heart with these. The first one was probably the one that I wrestled with the most. The first one is suicide is preventable. So this is just the way my brain works, but as I say that, I automatically go to the opposite, which is, okay, if it's preventable, then that means someone did something wrong if it occurred, because it could have been prevented. So that's how I spent a few years of my life. I spent a few years really wrestling with, what did I do wrong? What did I miss? How can I be the chief of mental health at an entire installation and miss, apparently, what was going on with an individual that I hung out with frequently, that I interacted with, that I called a friend and he called me friend, which, by the way, is pretty big for a Marine officer to call an Air Force officer psychologist a friend. I think he wanted to keep an eye on me on one hand, but on the other hand, I think we got along. So in talking about this, I do believe suicide is preventable. If I didn't believe that, I wouldn't be doing what I'm doing. On the other hand, I want to be very careful not to contribute to a climate, a culture of blame, of finger pointing, of if a suicide occurs, let's find the mental health provider, let's go through with a fine-tooth comb everything they did wrong, let's write down everything that they did wrong, and they're going to get in trouble. That is not constructive. That is not productive towards suicide prevention. It's not good for anyone, and it's not true, frankly. So suicide is preventable. We're going to spend some time in some future slides talking about two aspects of that as data points. And these two aspects have been influential for me in developing this as a core tenet. We're going to talk about how we know this at the individual level. We're going to talk about how we know about this at the population level. All right, number two, I wrestled with this a little bit too. Suicide prevention requires a public health approach. All right, I wrestled with what does that really mean? You're seeing that process playing out in terms of a definition and embodiment. And I also wrestled with a little bit of defensiveness, particularly around people saying we got to move upstream. And if my work clinically was not upstream, it's like, well, no, we've got to reinforce what we're doing here too. This isn't going to be just move up into some of these prevention aspects, and you're going to fail to appropriately attend to these really important and maybe more intensive clinical aspects. So I really fought the what I perceived as the binary approach here, and I was able to come to a point here where I get it. I get the public health approach when you are simultaneously attending to and not depriving clinically based approaches and interventions in milieu while you are building and developing the preventative, the community-based components. So I think that's why you see that spelled out so carefully, at least plottingly, within our work. Number three, this one was easy for me. Everyone has a role to play with regard to suicide prevention. The problem here, and what we find ourselves fighting, is that a lot of times suicide prevention becomes the work of somebody else and something that we watch, something that we monitor, something that we're interested in, but that's someone else's job and work. We are building a culture in the VA where suicide prevention is as much Gail Iwamasa as it is Matt Miller. Suicide prevention is as much a peer support counselor in Saginaw, Michigan, as it is Matt Miller. It's going to require all of us. And veteran suicide prevention is VA, but it's beyond the VA. And that's an important aspect too. So you're going to see us talking in this section about partnerships and the importance of partnerships beyond ourselves with regard to suicide prevention. We talk a little bit about the short term, the proximal, the long-term plan, but I'll get into that in a bit. So let's go to the next slide. So the concept of public health and the way we're defining it, and the core foundational truths, the three that I just reviewed, are linked into 4 targets. So we take the public health approach, we take the core truths, and it's almost like you say, where do we aim it? Where do you direct it now? Okay, we've got these things. Where do they go? They go in 4 directions according to what we've developed and what we believe. And I'm interested in your thoughts on this as well. Feel free to put in the chat if you think we need to think again, to quote a very good book that's out right now, or if you have some questions about any of these. But one target is building healthy and empowered veterans, families, and communities. Another is clinical and community preventative services. Then 3 is treatment, recovery, and support services. And then 4 is surveillance, research, and evaluation. So through these 4 targets, hopefully what you see is at least a couple things. Hopefully you see that there is suicide prevention, there is suicide intervention, and there is suicide postvention. And you need all 3. You need all three across clinical settings, and you need all three across community-based settings. The other aspect that hopefully you see in this is you see different sectors, segments of the population, and how you have to tailor prevention, intervention, and postvention, how you have to tailor clinical and community to these population segments. You have a segment of the population that includes everybody. So it's often called universal. It's all. You have a portion of the population that is at elevated risk, maybe not high risk. Then you have a portion of the population that's considered high risk. So again, you take these factors, you take these dimensions, and you put them all together, and then they're directed at these 4 targets. Next slide. Another important component, blueprint in the mix here is the VA/DoD Clinical Practice Guideline for suicide prevention. A lot of work's gone into this dating back to 2013 and prior. The latest update was in 2019. I think on our PowerPoint, you have a link that you can get. It provides the latest, the greatest information about evidence-based practices for suicide prevention. It contains 5 recommendations on screening and evaluation. And you can see as you look through this that we tried to carefully ground how we planned for the implementation of prevention, intervention, postvention services, clinical and community milieus, using the best information available from the Clinic Practice Guidelines. I encourage you, if you haven't had a chance to look at that, to take a look at that. There's other clinical practice guidelines VA and DoD have worked on as well that are just as relevant and excellent to learn from. So these are some of the ingredients that go into the cement, the foundation. Next slide.
Matt, before you go into that, one of the things I'm curious when people read the clinical practice guidelines, the first time I read them, I was very disturbed. Because when I read what the top evidence-based practices were, we've not fully deployed them in VA. And I think that's what's informed our plan. So I'm curious, as y'all look at that and think about where you are in your different facilities, VA and non-VA, how much of this are we doing every day that we do know has the evidence base behind?
Yeah, good point, Lisa. Yeah, I mean, that's one of the things that we wrestled with as we were putting all the pieces together here and talking about this as a team and moving from our foundational truths and into our strategic plan. It's like, oh my gosh, we got a lot of work to do, and we can't waste a single day. I mean, there's some evidence-based things here we have got to roll out and work together on immediately. We can't lose any time. Let's talk a little bit, Lisa, about what we're founded upon with regard to suicide is preventable. Next slide. We know that suicide is preventable. I know, I should say, I won't speak for you. I know that suicide is preventable at the individual level, and I have seen it with my own eyes. I have seen from our annual report, for example, that significant progress has been made with regard to suicide prevention within the VA. For all the bangs and hits that the VA takes and in suicide prevention, there has been significant progress within this area. And I think our anchors of hope are cases in point. For example, from 2017 to 2018, adjusted suicide rates fell among veterans with recent VHA care while rising among other veterans. The numbers involved there, 17 to 18, it went down 2.4% for veterans in VHA care. It went up 2.5% for veterans not in VHA care. Now, Anchor 2 gives you a little extended reference here and data point. From 2005 to 2018, we've seen a statistically significant decrease in suicide rates for veterans in VHA care diagnosed with depressive disorder, anxiety disorder, and substance use disorder. That's meaningful progress that has equated from 17 to 18 to 100 lives saved from 17 to 18 because of the progress that was being made with the individuals on the front lines rendering the care in clinically based settings, as well as the outreach work being done in community-based settings. Anchor number 3, we saw a decrease in our data for 2018 in suicide rates for specific veteran populations. Hispanic male veterans had a decrease in rate of suicide, and such that their suicide rate was lower than comparable non-veterans. One of the very few populations where veterans and non-veteran, it was lower for veterans. Women veterans. Women veterans in VHA care, their rate has gone down. 17 to 18, their rate went down. But women veterans not in VHA care, their rate has gone up, to the point that overall then women veterans are at 2.2 times higher risk for suicide compared to non-veteran women. Number 4 needs a little bit of explaining, but this is where a public health mindset comes in. We haven't seen an increase from 17 to 18. Sometimes when you're talking to Congress, sometimes when you're talking to the press, that's actually an important thing to say. When you're considering it from a public health perspective, it's also an important thing to say. When you're taking a look at it in terms of rise over run and rates, it is important and something to attend to when you see that the rise over run starting to change and flatten a bit. We have much more work to do, and we'll talk about that a little bit more. Anchor number 5, this is good news. There's a groundswell of support across agencies, across the country, across community, across clinical, and that's a good thing. Every time we get a question from the press, or every time we get pressed by Congress, there's a part of me that's uncomfortable, but there's a larger part of me that is thankful, because people are interested. There's interest, and that's a good thing. And that's something that we can build upon towards, again, directing in the right ways as best as possible. Next slide. So we're going to talk about core tenet number 2, but I do want to say, too, that we also know that suicide is preventable on a population level. Take a look at some of the work that's done with lethal means safety in certain populations or certain areas, and you'll see meaningful data regarding suicide prevention at a population level. Take a look at Kimberly Repp's work out of Washington County, Oregon, and some really innovative, scientifically based work she did as an epidemiologist, studying suicide in her area and county, and then converting that data into a community-based action plan, and what happened to the suicide rates when that occurred. Interesting at the population level. It can be done. Core tenet 2, suicide prevention will require a public health approach. Let's talk through this a little bit, probably not hit real in depth on a lot of slides, but we frame this first by talking about the fact that maybe I'm being a little oversensitive here, but I always find it important when we're talking about veteran suicide to emphasize, or at least say, it's not just veterans, folks. Suicide is a national problem. It's an international problem. It's a international and national problem that disproportionately impacts veterans, disproportionately defined from a statistical rate-based perspective. Next slide. I think this next slide illustrates a little bit of that, but you'll see in our annual report that you'll see another debate that we tried to settle. There's the debate about reporting suicide and talking about suicide and suicide prevention. There's count, there's measures of central tendency, and there's rates. The approach that we've taken the last 2 years is we're going to talk about all three. And we're going to start with count. We're going to make this a little bit like our staff books. We're going to start with count. We're going to talk about measures of central tendency, and then we're going to talk about rates. And we're going to talk about the advantages and disadvantages of each. Now, what you see in front of you is count related. And from this, you can see that from 2005 to 2018, there's been a 47% increase in count of adult suicide in American population. At the same time, across the same time, you see that there's been a 6.3% increase in count for veteran suicide. Now, the issue with that is it's important data, but it also needs to be considered in the context that across that same time, the veteran population has dropped at a rate of about 2% annually, about 20% over the whole, while the U.S. population has increased. So when you look at it from a rate perspective, the fact that the count is staying around that 6,000 mark, the rate is still going up because the population is decreasing. It's a numerator denominator thing, but beyond that, it is a indicator that suicide is a problem within the veteran population, and it's a problem within the population as a whole. Next slide. All right, so how this then converts to averages. This is probably my least favorite, to be honest with you, but it's the one that some groups focus the most on. So it's one that we try to provide education around as we're providing it. So if you've heard that the veterans are dying at a rate, wrong word, if you're hearing that they're dying at a rate of 20 per day, that's inaccurate according to our latest data. According to our latest data, what's accurate is 17.6 per day. The year prior, 17.5. And you can also see in the data that that's not the highest it's been since 2005. That's not the lowest that it's been since 2005. All points that we try to leave as points for review, discussion, and consideration as we're sharing the facts. Now let's talk about rates a little bit, and I think that's in the next slide. Obviously, from a statistical, biostatistical, epidemiological perspective, rates are likely one of the more valid ways to go here. From a rate perspective, what you can see here, picture worth 1,000 words. The dark blue is veteran. The light blue is non-veteran. The dashed line represents adjusted rates, so age and sex adjusted specifically. And the solid line represents unadjusted rates. Point here being, when you take a look at this, the veteran rates have increased, so have the general population rates. Again, though, when you start breaking it down into some specifics, you'll start to see that the veteran rate with VHA goes down 2.4%, but the veteran rate non-VHA goes up 2.5%, and that's why you kind of see that evening out there between the two of them there at the end of that graph. Now, the fact that the non-veteran rate went up 2.5%, it's important, I think, to consider that same rate went up 11% in the 2017 data. So it's technically defined, it's improvement. So all important things here to keep in mind with regard to this. And what we try to talk about the most when we're talking about understanding the numbers is we try to talk about the rates. Next slide. We also emphasize from a public health approach. So why am I talking about all these numbers? Because a core of the public health approach is data-driven. And data-driven includes local data. So it's important that we link people not only to this national data, general population, veteran population, substrata of veteran population, but then we also link that into state data that states and local areas can take a look at and can use to inform their suicide prevention plan. Remember, a lot of times that we've seen so far, change in a community-based intervention level is driven by community-based data. You'll see that as an example I used in Kimberly Repp's work, where she saw some data points, and then when she addressed those data points with interventions, suicide rates started to decline. There's ways to resource or to reference and access our state-based resources. Lisa is, man, she's just the best at everything, but hyperlinks, she's the best at that too, and you're going to see the world's best hyperlinks in this presentation. So she's got them here too for you as well. Next slide. Here's an example. I wonder why we picked Texas. That might have been because that's Lisa's home state. But this gives you an overview of what you can see in our state-based data and how you can start to wrestle with and engage the numbers and the data towards localized, regionalized, public health-driven suicide prevention plans. Next slide. So this has converted into, and we're not going to have time to go through all of this, but I just want to say very broadly, this has converted into our strategic plan. I think, Lisa, I'm going to try to summarize this, and maybe you can kind of go through some of the slides as I'm going and illustrate it as I'm talking, but I'm going to give the 5-minute version of our strategic plan, linking the long-term plan with the proximal plan. So we started taking everything we've talked about, the 3 foundational truths, the definition of public health, the 4 targets, and then saying, so what's the strategic plan? What are we doing here from a long-term perspective? And that became known as SP 2.0. Probably one of our biggest weaknesses is we're terrible at creatively naming innovations, but it's SP 2.0. And then we started to put content, meat, to the community-based components and to the clinically based components. The structure that we put to the community-based components, we want to be very careful to not say, we're going to hire a bunch of people, and bunch of people go out into the community. We don't know what to tell you to do, but go out into the community, and when you go out, that's flyer. When you go out into the community, do something, and hopefully we'll see the rates go down. We've really anchored our community-based approach in 3 approaches, paradigms. One is a regionally based model in the VA speak. That's a VISN-based model that focuses on community coalition building between local facility, VISN, and local community. The second is a veteran-to-veteran based model. Together with veterans is the structure and the program within which we embody this approach. We've grown to 16 communities within this and are hoping to continue to expand. Here, we're not looking so much at having an outreach individual foster, reinforce a community collaboration between the facility, the visit, and county representatives. Here, it's veteran to veteran with technical assistance across rural communities. The third approach is state-based, and this is where we use the structure and the vehicle of our governor's challenge, where governors appoint representatives across the state to represent the office of the governor, and then to work with us along with SAMHSA for the development of a state-based suicide prevention plan that we then offer technical assistance, support, and reinforcement for. On the clinically based side of things, we're really focused on going through that clinical practice guidelines and what can we do? What do we need to do? So one thing Lisa and I and the team were really convicted of is we have got to increase access and break down barriers to these evidence-based clinical suicide prevention approaches. So we're starting with CBT SP. We're going to break down geographically based barriers, obstacles, and we're going to offer this across our clinical resource hub centers nationally. In doing that, we're going to be able to patch this in hub and spoke to veterans across the country, and we're going to hire 100+ licensed providers to deliver this service and increase access to this important suicide prevention intervention. We're also going to add to that in a planful way across time, safety planning interventions, dialectical behavioral therapy, and some other approaches as well. We also are emphasizing along the way there is a link in the data and the research between outpatient mental health staffing in a community and suicide rates. So we emphasize that yes, while you're not going to hire yourself out of what's occurring with suicide in our nation, access to adequate amount of licensed mental health providers and care teams makes a difference and is meaningful. So we emphasize that. There's something that Lisa went through quickly is we try to emphasize how those areas overlap, and we do that using that Venn diagram. Here's a slide with the data supporting what I just said in case you question it, which is a wise thing to do, by the way, and I support that. So does Lisa. She does it every day. But here's some of the data that's driving that. Now, Lisa and I are sitting there. She's not, but I am. We're sitting there, and I'm kind of patting myself on the back as we develop this SP 2.0 and the three pillars, paradigms of the community-based model and the starting point, CBT-SP, of the clinically based model. And that moment of self-congratulatory feeling ended quickly when I said to myself, but what are we doing right now? I'm sitting at Panera eating a sandwich. Veterans are dying. What am I doing right now? Am I going to sit there and say, I don't know, but we got a 3 to 6 year plan. Give me time. Let's see. That was not adequate for me. That was not adequate for Lisa. That was inadequate for the team as a whole. So we got ourselves out of Panera. We called up our data surveillance team and we said, What do we need to do to flatten the curve based upon available information now? What's the number? What's the percent? And the number and the percent that we got back for this year is 7% and 463 veterans additional saved. I want 10%. I want 100%. Team, I want you to dive into the data, and I want us to figure out the most effective, meaningful target point this year for us to address the 7, the 10%, the greater than 10%. That created a plan that we call the SP Now plan. I told you creativity and naming is not our gift. We put together from the data that if we target lethal means safety, suicide prevention in medical populations, prior VA users who have not been with us for the last 2 years, but have been with us in the last 10 years, 2 per day from that group die by suicide. Suicide prevention program enhancement, such as how can we improve and tighten up what we're doing with REACH, what we're doing with SPED, what we're doing with risk ID. And you're going to see then our focus on those sorts of things as part of Plank 4. And finally, then, how can we use paid media for us to, thanks, Lisa, how can we use paid media for us to get the word out? And not just get the word out, but convert awareness into engagement in meaningful ways for suicide prevention. So that brings us into a very broad overview of some of the resources under the heading of core belief number 3, which is it's going to require all of us. We believe that from the bottom of our hearts. That is not a trite, cliche expression on our part. And it's also not an abdication of our responsibility. I feel very responsible for what is occurring with suicide rates with our veterans, and I should be, and I should take responsibility. And you will not hear me say, well, it's all of us, don't look at us. Now, what you will hear me saying is, if it's not going in the right direction, then it's time to rethink our approach, and it might be time to rethink Matt. But within that, you'll see me turn to you and say, it's all of us. What can we do together? Here's a great slide, and Lisa, I would offer this in conclusion for ways for you to think how you can implement this principle individually and within your community. What are some ways that you can help to promote identifying service members, veterans, and their families, promoting connectedness and improving care transitions, increasing lethal means safety and safety planning? Lisa, help me clean up the mess that I've made in a blur of verbiage.
I will try to do that, sir. I don't think it was a blur of verbiage. I think that the call to action we have for each of you is to be thinking through your own units of influence, if you will. You know, reflect on the national strategy, reflect on the clinical practice guidelines. What are some of the things that you could powerfully bring home within your area of influence, first in your workplace? But from there also, I think this next slide really here shows what can we do right now for those around us. Matt, I'll end with a story. Matt knows it's been a rough week. It's been a real rough week. And I try to start my day off with kind of meditating and thinking through ways to focus myself in a positive manner. And after I did that yesterday morning, I just heard something in me saying, Lisa, you need to write a thank you note to a veteran right now. And you need to remember why it is you're doing what you're doing. My dad's adopted dad, I'll call him a World War II veteran, was a man who came alongside my dad after Vietnam. Really rough period of my dad's life. My aunt had died by suicide 2 years after he came back from Vietnam. And it was a rough period for him and for family. And this gentleman came alongside my dad and mentored him, was a father figure to him, a father that he really hadn't had, and loved on our family. He's in hospice now. And I just felt this voice, write that note to Mr. Stetler. Write that note. And as I was writing that note, I was able to tell him, I think you saved my dad's life. You saved our family because of the way you came alongside and loved on him and mentored him and coached him. And that was a reminder to me why I'm here, why you're here, serving in the way that you're doing is we are coming alongside saving lives. Sometimes it's through what we're doing clinically, and sometimes it's what we're doing with our next door neighbor, with the person you come around your arm and put your arm around them and help them walk through some dark times. And that's what I encourage you to do, is take this information here and think through, how can I infuse what we know from the evidence? How can I be evidence informed in my workplace and bring this home? And how can I connect not only with veterans, but everyone around us to help folks through hard periods that we're all going to have? So thanks for letting us have an opportunity to connect with you today. And Dr. Iwamasa, appreciate all your service to Division 18 and in VA, because I know what you're doing each day makes a difference too.
Oh, you guys are so amazing. Thank you so much. This was such a rich rich webinar with not just information and data, but really giving us a flavor for your passion. And really, I think what's helpful is, the stories that you all told, we can all do this together, but we can always do it individually. By ourselves, and it doesn't have to be a huge thing, but little things that we do really do make a difference. So thanks to both of you. I know people are dropping off now. You probably all know how to get a hold of Drs. Miller and Kearney. This webinar will be posted on the Division 18 VA section website, probably in, I don't know, a couple of days. And then also those of you who are registered will automatically get a link to the CEU survey. Division 18 members get one free CEU from it. Other folks, it's just a paltry $15. So well worth the money for sure today. But thank you both for presenting. Thanks for taking time out of your busy schedule. Thanks to all of you who have attended, and we really do appreciate everything that folks are doing to take care of veterans. I think we'll have to end on that note, folks. So thanks, everybody. Take care. Have a good